All right, excellent. Thanks so much. So I know it's been a long afternoon or long day starting early on, so I appreciate everybody sticking around. And thanks, Ravi and Vinay, for putting together this very nice conference. I think it's a very nice forum to have these kind of nice conversations. And I won't be as entertaining as Ravi was earlier today, so I apologize about that. So we're going to talk a little bit about filanosib, or Area 520, which is a novel kinesin spindle protein inhibitor. Disclosure slides. And so as we get started, I think really when we start talking about how we really advance myeloma, there's really three strategies in my mind. One of them is understanding mechanisms of drug resistance. We've made lots of progress over the last decade with proteasome inhibitors and IMiDs. And one of the ways we can move forward is understanding mechanisms of resistance and how do we overcome that. And I think panobinostat, for example, plays very nicely into that. Second kind of strategy is new drug development with novel targets. And I think this is where filanosib can potentially play a role. And finally, the third strategy is really our immuno-oncology platform, and I think that's where elotuzumab and our anti-CD38s really play a role. So I think these are all really complementary to each other in terms of how we advance myeloma as we look forward. And so talking a little bit about one of these strategies with new drug development and a novel target. So kinesin spindle protein is a new drug target. It's a microtubule motor protein that's required for mitosis and separation of the spindle pull. And KSP inhibition by drugs including filanosib really prevent formation of this bipolar spindle and lead to a monopolar spindle and cell cycle arrest and cell death. Area 520, as is previously known, or filanosib now, is a selective KSP inhibitor, really has a novel mechanism of action compared to our proteasome inhibitors and IMiDs. And so we'd expect to see, not to expect to see a cross resistance with some of these other drugs and a different side effect profile as well. Preclinical studies both show activity both as a single agent as well as combination with both proteasome inhibitors and IMiDs. That really led to the clinical trials that we'll talk about next. So there's a phase 2 study that was presented both last year at ASH as well as 2 years ago as a single agent as well as in combination with dexamethasone. And so we'll present both of these. And so this is a cohort 1, which is single agent 520. And the phase 1, we established an MTD of 1.5 milligrams per meter squared. We started off at 0.75 and went up to 2.25 milligrams. At the end of the day, the MTD was 1.5 milligrams per meter squared, dosed every 2 weeks with growth factor support. Cohort 2, which we'll also describe, added in dexamethasone just weekly, dexamethasone at 40 milligrams once weekly, in addition to the 520 on days 1, 2, 15, and 16. Slightly different inclusion criteria or eligibility criteria between cohort 1 and cohort 2. Cohort 1 with the single agent was really patients with relapsed or refractory disease, so these patients must have had prior bortezomib and an IMiD and relapsed or refractory. Cohort 2 in the patients with combination with dexamethasone were much more heavily pretreated, so these are patients with triple refractory disease, so must have been refractory to full dose bortezomib, lenalidomide, dexamethasone, refractory to the last line of therapy, as well as have adequate prior alkylating-based therapy. So very heavily pretreated patient population that was targeted here. These are the demographics with 32 patients in single agent 520 and 55 patients with combination with dexamethasone. And really what we'll see here is that these patients were heavily pretreated again with 5 years since their prior time of diagnosis and 3 years in the relapsed patient population. These are the prior therapies, and what we'll see again with the 520 is by protocol definition, all these patients had prior bortezomib, IMiD, and refractory to both, and so these are patients who are triple refractory, and the majority of them had prior transplant as well. In 520 is a single agent, again, about 40% of the patients had triple refractory disease, but they all had prior IMiDs and bortezomib-based therapy, and the majority of these also had prior alkylating-based therapy and transplant as well, so still a heavily pretreated patient population. These are the non-hematologic grade 3 and grade 4 events, and so this is actually a very well-tolerated therapy. In fact, we see very few non-hematologic toxicity. It's really limited to a few patients with pneumonia, hypokalemia, back pain, and fatigue, but really what we don't see is peripheral neuropathy, what we don't see is end organ damage, and tends to be very well tolerated in these patients. Hematologic toxicity is something that we do see with filanosib, and this is a kind of expected on-target effect with both neutropenia and thrombocytopenia, as well as anemia. These are grade 3 and grade 4 events. But I don't think this tells really the whole picture of what we see with filanosib. And so one of the questions is, despite growth factor support, we see this incidence of neutropenia. But again, what we see here is that very low incidence of clinically significant bleeding events or febrile neutropenia. I think this slide here really best describes what we see with flanacib in terms of its neutropenia and thrombocytopenia. And so you'll see these patients, and the little black stars on cycle 1 or day 1 of each dosing. You'll see this very transient drop in their neutrophil count or transient drop in their platelet count that recovers very nicely by the time they're dosed 2 weeks later. And so you'll see these incidents of neutropenia and thrombocytopenia are very transient and not prolonged. And the other thing that you'll see as well is that this is patients dosed out to 250 days. But we'll have patients treated out to 2.5 years now, and you'll see a very similar pattern. And what we're trying to get at is we don't see a bone marrow failure or a bone marrow loss of function over time. So despite this, the baseline platelet count and neutrophil count stays very stable. So they recover back. We're not burning out their marrow after several years, and so it stays very stable. So I think these are very transient events that we see that are not clinically significant. Again, looking at the SAEs and discontinuations, majority of these patients came off for progressive disease, and actually very few patients came off for adverse events, again suggesting this is a rather well-tolerated therapy. One of the other stories that came out with flanacib is really a selection biomarker about how do we best choose patients for this therapy. So I think this is still a work in progress, and the story has not been fully written, and this is really hypothesis generating. But one of the things that we saw was AAG, or alpha-1 acid glycoprotein, which is an acute phase serum protein, can bind to 520, and increasing concentrations of AAG will result in increased IC50 for 520. Importantly, as we started looking at this, there's, at least what we see in the published literature, there's no correlation between concentrations of AAG and our common myeloma prognostic markers, so we don't think this is a prognostic marker. And so the hypothesis is that patients with high AAG levels at baseline will have subtherapeutic exposure and therefore potentially lower response rates. So when we looked in the earlier studies with single agent 520 as well as in combination with dexamethasone, if we look at here concentrations of AAG and a cutoff of 1.1, and this is time on therapy, you'll see patients with high AAG levels in fact stay on therapy for a shorter duration of time, for a median of, for a range of 1 to 5 months. And these color dots here are patients that responded. You'll see more of these patients with low AAG levels have a tendency to stay on therapy longer. This is also seen with our response rates when we try and correlate AAG concentrations to response rates. And so when we look at all patients with high AAG levels and then low AAG levels, we'll see that patients with essentially high AAG levels have a no response or no activity, both as single agent or in combination with dexamethasone. And then patients with low AAG levels are the patients that respond, and about a third of the patients respond when we look at those. And so, again, this is really hypothesis generating, a quite marked differentiation between those patients with high and low AAG levels. And so I think still a lot has to be learned about this, but this is very intriguing. And finally, the other picture that we see coming out of the single agent experience is that when we look at patients with other novel proteasome inhibitors, including the carfilzomib, the ixazomib, and pomalidomide, again, we'll see patients with low AAG levels in those patients with these other novel therapeutics still have preserved activity. And so again, suggesting that flanacib is active in these patients and it's not cross-resistance, again, to other PIs and IMiDs, and similar to what we saw with the bortezomib and IMiD story. So as we move forward, really, I think the next step is combination therapies, and so we'll present some data that we've done at Anderson, looking at a phase 1 study of flanacib plus carfilzomib in patients with relapsed refractory myeloma. And so this is a traditional 3+3 design phase 1 dose escalation study. We had 2 parts of it. Part A was looking at escalating doses of 520 plus a fixed dose of carfilzomib at 2027, which is the currently approved dose, and then a dose expansion there. Then we had a second part B looking at a higher dose of carfilzomib and escalating carfilzomib up to 56 milligrams per meter squared. We'll present both of those data. Looking at the study design, there's very nice overlap between carfilzomib and flanacib. So carfilzomib is dosed on the standard days 1, 2, 8, 9, 15, 16, with very nice overlap of flanacib on 1, 2, and 15 and 16. Important notes, carfilzomib was given as a 30-minute infusion, so not the 10-minute infusion that we've used at these lower doses. And again, this is a relatively steroid-sparing regimen with only just 4 milligrams of dexamethasone given prior to carfilzomib. And again, growth factor support. These patients must have had prior bortezomib and prior IMiD, or importantly, refractory or intolerant to prior bortezomib-based therapy, and were not eligible for autologous stem cell transplant. So we presented this data at ASH, and we had enrolled 20 patients at that point in time, with a median of 4 lines of prior therapy. Again, majority of these patients had prior stem cell transplant. They all were bortezomib refractory or intolerant. Majority were also lenalidomide refractory or intolerant. And in fact, in the dose escalation, we allowed patients with the prior carfilzomib in 520 as well. So 6 of the patients had prior 520 or carfilzomib. In the non-hematologic AE events, really very few grade 3 and grade 4 events that we saw. Only 1 patient with grade 3 neuropathy, but otherwise very few non-heme toxicities. Hematologic adverse events were as expected. Again, we saw the neutropenia and thrombocytopenia, but again, very similar to what we saw with 520 as a single agent as well as dexamethasone. These are all very transient and not prolonged. When we look at the cohort summary, again, we start off at flansib at 0.75 milligrams per meter squared. Again, 1.5 is the MTD as a single agent, and we're able to actually escalate to 1.5, a full dose of flansib. 2 DLTs were seen. One was a patient with non-neutropenic fever with parainfluenza 3 at the end of cycle 1. And in the maximum, or cohort 4, again, we saw 1 patient with non-neutropenic fever with a temperature of 38.0. So again, a very well-tolerated regimen. And in fact, this is not the MTD, as we did not hit DLT criteria. When we look at really very early activity, early signals of activity, again, these are all 20 patients that we see. And when we look at overall response rate very early on, we see about a 35% response rate and 60% clinical benefit rate. We see a number of patients that are still on a therapy out at 16 and 18 cycles of therapy. And when we look at these patients in the full dose, 4 out of the 6 patients responded and are still on therapy at this point in time. Oops. So in conclusion, I think flansib really, to me, has started to demonstrate single-agent activity. It's the first time we see single-agent activity outside proteasome inhibitors and IMiDs in terms of a new class of drugs with small molecule that's active. AAG is, I think, a very interesting bioselection marker that's, I think, hypothesis generating. Much more has to be determined about the role of AAG. Importantly, we've shown that's well tolerated, especially in combination with proteasome inhibitors, including carfilzomib. It's also been combined with bortezomib as well, and that data was presented at ASH, again suggesting that we can combine it with bortezomib as well, with really low incidence of non-hematologic adverse events. And so really looking in the future, there's a combination of bortezomib that's ongoing right now. There's a combination with pomalidomide plus flansib that's planned in Spain. A phase 2 trial of carfilzomib and flansib is ongoing right now. And then the phase 3 trial is planned later this year as a registrational trial of carfilzomib plus or minus flansib. And also a larger phase 2 single-agent flansib trial is also planned as well. Coming back to our ongoing phase 1, we are in the dose expansion right now. We've also started the Part B dose escalation, escalating carfilzomib now up to 36 and 45 milligrams per meter squared, and that is ongoing now. So we'll stop there.